Welcome to Part 2 lesson related to interventions for clients with urinary problems. In this lesson, we are going to discuss urethral strictures. Urethral strictures are caused by narrowed areas of the urethra. It is often secondary to sexually transmitted diseases or trauma during catheterization or urologic procedures or even childbirth. The net effect is going to be obstruction of urine flow. This will put the patient at an increased risk for UTIs and or overflow incontinence. With urethral strictures, surgery or dilation is necessary. Okay, let's talk about incontinence. Incontinence is an involuntary loss of urine that is severe enough to cause social or hygienic problems. It is not a normal consequence of aging or childbirth and is often a stigmatizing and underreported health problem. Many people suffer in silence, are socially isolated, and may be unaware that treatment is available. Continence occurs when pressure in the urethra is greater than pressure in the bladder. For normal voiding to occur, the urethra must relax and the bladder must contract with enough pressure and duration to empty the bladder completely. Voiding should occur in a smooth and coordinated manner under a person's conscious control. The most common forms of adult urinary incontinence are stress incontinence, urge incontinence, overflow incontinence, and functional incontinence. Or a patient may experience a mix of these types of incontinence. About 85% of patients that experience incontinence are female. 15 to 30% of older adults live out in the community, and 50%, maybe even higher, of incontinence are related to nursing home residents. Incontinence may have temporary or permanent causes. Let's discuss in detail the most common forms of incontinence. Okay, first off is stress incontinence. This is the most common type. There's loss of small amounts of urine during sneezing, coughing, or lifting. It's commonly shortly after childbirth due to the pelvic muscles being stretched or weakened. It's also common at menopause due to vaginal and urethral tissue thinning and weakening. The next one I want to talk about is urge incontinence. You can't suppress the signals from the brain to hold the urination, and then the leak is large amounts of urine suddenly. It's also known as overactive bladder. It's linked to CVA, PD, MS, spinal tumors, UTI, BPH, and bladder irritants. Then we have overflow incontinence. The bladder has reached maximum capacity, and then urine leaks to prevent the bladder from rupturing. And last but not least is functional incontinence. There is a loss of cognitive function, and then you have to be aware of urination need to be continent, but in these clients, they don't have the capacity to interpret the signals from the bladder to the brain to the bladder. So, during the assessment phase, you want to ask questions that are essential because incontinence is underreported. May cause social isolation, and especially if it's not treated appropriately. Many clients are embarrassed regarding urinary issues because they associate it with sexual issues. You will perform a physical assessment, laboratory assessment, imaging assessment, and other diagnostic assessments. So a few of the interventions that you can use for like stress incontinence is have the client keep a diary. Some of the behavioral interventions would include to diet if the patient's obese or to avoid bladder irritants, to do Kegel exercises. There's also drugs for management such as estrogen cream or vaginal cone therapy. And then surgery may also be offered in some cases, but not used in urge incontinence. Well, we can discuss a little bit about bladder control. Drug therapy and behavioral interventions for stress incontinence require the patient's active participation for success. So, a summary of bladder control drugs would include an understanding that these drugs relax the smooth muscles and increase bladder capacity. And some examples would include ditropan, probanthine, detrol, and tricyclic antidepressants. So what can we do for bladder training? Bladder training is an educational program to allow the patient to control his or her bladder, not the bladder control the patient. During training, you would gradually increase the interval between voids. And then there is the potential for habit training, which is simply staying on a scheduled void, such as voiding every 2 hours or voiding every 3 hours. Okay, let's discuss some bladder compression. There is the Crede method, the Valsalva maneuver, double voiding, or splinting. The embarrassment of incontinence can be devastating to a patient's self-esteem, body image, and relationships. The unpredictable nature of incontinence creates anxiety. Here are some methods to assist patients in avoiding embarrassment. Some of these methods include self-catheterization, intravaginal pessary support, penile clamps, condom catheters, and/or pads. You also want to remember to avoid calling these incontinence aids such as diapers due to the association of diapers being associated with babies. So we discussed catheters in part 1 of interventions for clients with urinary problems. And now in part 2 we're going to discuss Foley catheters are appropriate. Can you think of when catheters are appropriate? Well, they are appropriate if the patient is experiencing a skin breakdown because the wet skin causes maceration. Then the catheter should only be used temporarily until the skin heals. Sometimes catheters are used for terminally ill clients to provide comfort. And then another example of an appropriate use of catheters would be for the critically ill client that needs constant, accurate output monitoring. This concludes part 2 lesson of interventions for clients with urinary problems. If you have any questions related to this lesson content, contact the instructor.